I can start. Do I have to ask if they can hear me or? Yeah. Oh, you can hear me. Okay, okay. Okay, thanks. Okay, good morning, everyone. Thank you for coming to the monthly combined general surgical meeting. I'm very excited to have this hybrid format. I think this is the first time we're doing it, even before the pandemic and after the pandemic. So welcome to KK Hospital and welcome to the Zoom meeting. I'm even more excited to be able to introduce Professor Han-Byoel Lee. Um, he flew all the way from South Korea overnight. He arrived this morning. I guess all of you know him here, and he has is a very important roles in many areas. He's the associate professor in breast care center, biomedical research institute, Department of Surgery, and Cancer Research Institute in Seoul National University. And he's the head of International Committee Korean Breast Cancer Study Group, KBCSG, and he's a Deputy Secretary General in Korean Breast Cancer Society Scientific Committee Global Breast Cancer Conference, which we were there last month, GBCC. And he's the co-founder and Chief Medical Officer in DCGEN as well. So he's going to share with us about his work. So all yours.
Just duplicate it. Yeah. Okay, I hope everybody can hear me well. Good morning. It is a great pleasure to be here. Please. Oh, yeah. Yeah. Mhm. Oops. Okay. Good morning, everyone. We have quite a few audience in person. Actually, I didn't know that it was in Zoom format in recent years after the COVID. I just thought that being in person might be more appropriate and to meet you all here in Singapore. And I didn't know that I caused some trouble having you all here in trouble in person. But it's good to be back. It's my third time here in Singapore. I have good friends, so many friends here. Good to see them all in person. So I got this great opportunity to talk to you about a multi-gene assay called the OncoFree for breast cancer. We have a lot of multi-gene assays, such as the Oncotype DX mammoprint being used commercially worldwide. But we do have some differences in Asia and the West. So I would like to talk a little about that. So this is my disclosure. So as was introduced, I have my main affiliation is Seoul National University Hospital, of course. But I founded a company called DCGen back in 2017. But it's more like this. So 80%, 90% of my work is in the hospital. About 10 to 20% maybe is in the company. And today's talk, I will try to have it as 90% academic and maybe 10% in the company side. So I have to. Can I? Okay. Okay. So when we make clinical decision making for our treatment of breast cancer, we use prognostic and predictive markers, right? So traditional markers such as age, tumor size, lymph node status, as well as ER, PR, and HER2 are used. And now we use multi-gene tests in our everyday practice. So I'll have to talk a little about multigene assays that I'll be talking up to you today. It will be about RNA-based tests. So we call multigene panel testing for DNA-based tests when we evaluate somatic mutations or germline mutations, right? But the multigene assay that I'll be talking to you today is about RNA tests. And we look at different gene expression of different genes, multiple genes, put them together in an algorithm, which gives us a score, and then we classify them, the patients, according to the score, into high or low risk. So we all know about the molecular subtypes. For the different molecular subtypes, they have different survival. We have surrogates, hormone receptors, and HER2 that we discriminate all the subtypes. So for TNBC, they are more aggressive. For HER2 enriched, we now have HER2 targeted agents for better response. But for luminal type cancers, although the main treatment is hormone therapy for all luminal type cancers, there is a subtype called luminal B where chemotherapy should be given and it benefits the patient. So it is really important to discriminate between luminal A and luminal B. And in order to do that, since 2008, this is the NCCN guidelines, they strongly recommend considering the 21 gene RT-PCR assay, which is the Oncotype DX. And if the recurrence score is less than 26, chemotherapy could be omitted. Oncotype DX, briefly, is a 21 gene assay, but 5 of those genes are reference genes. So actually 16 genes are the ones that are that gives the final recurrence scores. And according to score, the patient is categorized into different risks for distant recurrence. So before this TAILOR-X trial, this is a prospective randomized trial. Before this trial, they were using the Oncotype DX with the retrospective analysis and development data, and now they have the TAILOR-X trial data. So they divided the patients into 3 groups. If the patient has a recurrence score of less than 11, chemotherapy was not given. If it was more than 25, higher than 25, chemotherapy was given. But for the group in this recurrence score of 11 to 25, they randomized patients into endocrine therapy only and endocrine plus chemotherapy. So for patients with low risk of less than 11, they showed a very, very high distant metastasis-free survival rate at 5 years at 99.3% without chemotherapy. So actually, I started treating breast cancer patients only 9 years ago. I started my fellowship in 2014. So back then in Korea, most patients, regardless of hormone receptor subtypes, most of the patients receive chemotherapy, right? But according to this data, if they have a low score on Oncotype DX, all these patients can be safely omitted of chemotherapy. This is the data from the German group where they enrolled some more high-risk patients. So high risk, no negative patients, and also no positive patients. And if the patient has a recurrence score of less than 11, their distant disease-free survival rate is a very high 97.7% without chemotherapy. So for a lot of the luminal type cancers, chemotherapy is not beneficial for the patient. So for the intermediate group, where they randomize patients into endocrine therapy and endocrine therapy plus chemotherapy, for the whole group, there's no difference at all. So that we can, at a glance, we can say that these patients would not benefit from chemotherapy. However, when they did a subgroup analysis for patients under 50 and under, obviously, so this is KK Women's Hospital, and you know all about women better than I do, right? So because women have a very, very important change around their 50s, namely menopause, this could be very influential, right? So they reported that there is chemotherapy benefit for patients who are under 50 years old and have a recurrence score between 16 and 25. And for 21, between 21 and 25, they have a 6.5% chemotherapy benefit. So the next year, this was reported in 2018. The next year in ASCO meeting, they brought out this very busy slide. To summarize, for young patients, if the patient has a recurrence score of more than 20, chemotherapy should be given. And if they have a recurrence score of 16 and over, and if they have clinical high risk, chemotherapy should be given for those patients as well. So that's kind of ironic, right? We try to avoid using clinical values to decide on adjuvant treatment using Oncotype DX or other multi-gene assays, but we have to come back to the clinical features for younger patients. Now they have updated 12-year data, which was presented at the San Antonio Breast Cancer Symposium last year. And the same trend is very evident. So if the patient has a recurrence score of more than 15, they have an up to 7.6, 7.8% absolute chemotherapy benefit. The same trend. And the most benefit is for patients between 40 and 50. So the really, really young patients under their 40 does not really, there's not much difference between patients who had received chemotherapy or not. But we do have to note that the number is very small for these patients, okay? Anyways, for Oncotype DX, according to the TAILOR-X trial results, we have to be very careful when interpreting these results, especially for a recurrence score of between 16 and 25. But this epidemiology comes into play for our Asian patients, right? This is the graph for United States, where Oncotype DX was developed. Most of their patients are in their 70s and even the 80s, right? And the patients enrolled into the TAILOR-X trial, only 30% are under 50 years old. Whereas, especially for Korea, we still have our peak age in our 40s. I didn't know, but Singapore is has a very high median age group for breast cancer. But anyways, there is also a difference for Asian Americans in contrast to white Americans in the age group. This is very different from colorectal cancer, for example, where it goes up and up and up as the patients get older. This is the latest data, I think, from Singapore. I noticed that Singapore is very, very similar to the United States. I don't know if do you feel that way? Do you have a lot more older patients? Mm-hmm. Mm-hmm. Right. Uh-huh. Right. Right. Uh-huh. Right. 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 So yeah, we see the shift, and also in Japan is similar, right? But this proportion in the 40s and early 50s will not change. The proportion of the older women will go up and fill this space. So anyways, okay. So we also have this data from the responder trial, which looks at node positive patients. So for patients with 1 to 3 lymph nodes, they did the Oncotype DX. For recurrence score of 25 and under, they randomized patients into chemotherapy and no chemotherapy plus endocrine therapy. And for all participants, there's no difference between patients who receive chemotherapy and endocrine therapy. And also for postmenopausal patients, no difference at all. However, there is a difference for premenopausal patients. So about 4%, 3.5% absolute difference in terms of 5-year distant relapse-free survival. So the conclusion of the responder trial was to give chemotherapy regardless of Oncotype DX for node-positive patients. And this was incorporated into the NCCN guidelines since 2022. For postmenopausal patients, they include N1 patients into this similar recommendations. However, for premenopausal patients, it's the same as the one as before. However, for node-positive patients, they don't say you must give chemotherapy. So if candidate for chemotherapy, you still should consider gene expression assay to assess prognosis. And they also give you an option to offer ovarian suppression instead of chemotherapy. And I've talked to a lot of the doctors in the United States and also in Europe. I asked them, do you give chemotherapy to node-positive premenopausal patients? And they say no, not always. So if they think the other clinical factors are favorable, they go on with the Oncotype DX. And if it's very low, they offer ovarian function suppression instead of chemotherapy. That's the practice right now. And that's the area that has a big question mark. So this AJCC staging 8th edition in 2018, they incorporated something called the pathological prognostic stage. Traditionally, if we use the size criteria for T, right? So even if the patient is T2N0, and if their HER2 status is negative and ER is positive, and they do the Oncotype DX, and if the score is less than 11, they override the traditional stage 2 into 1A. So, and they also state that future updates to the staging system may include results from other multi-gene assays as well. And these are some of the multi-gene assays that should be considered. One of which is the MammaPrint developed in the Netherlands. Actually, MammaPrint was the first multi-gene assay that was, oh, hi, I didn't see you. Anyway, that's Suzanne, by the way. So this was actually the first test developed in the Netherlands, and they compared 5-year disease-free survival rate with distant metastasis at 5 years. And they also have a large-scale prospective trial. It's a very, very complicated trial, but the bottom line is that they look at clinical risk and also genomic risk. And their main primary test population is patients with high clinical risk, but low risk on MammaPrint. And their first announcement was that their 5-year distant metastasis-free survival is at about 94.7%. So they say, even though the patient has a high clinical risk, if the patient has low genomic risk, you can spare them of chemotherapy. They also have this 8-year follow-up data. You can see the big separation. If the clinical risk and genomic risk coincide, they have a very good 8-year survival rate. If both are high, they have a very low survival rate. And in the intermediate, if they in the middle, it's acceptable 90% at 8 years. However, again, for patients who are postmenopausal, over 50, there's no difference whether they receive chemotherapy or not. But for the younger patients, they have chemotherapy benefit. Absolute benefit at 8 years for younger patients is 5%. So according to this data, and of course, it's the ASCO guidelines, which was developed in America, where they developed Oncotype DX. They state that for patients 50 years of age or younger, if the patient has a high clinical risk or node-positive disease, they should not use the MammaPrint for these patients. There's a very strong statement, right? Yeah, for me, I have a conflict of interest, but I think that could be similar for Oncotype DX, maybe a little bit. So, and also MammaPrint, they also have announced this data from ultra low risk. They have a score of very low risk, which has a 99% survival rate at 8 years. But the cohort consists of very, very low clinical risk features. So you might want to check this paper also. There's also the EndoPredict which was developed in United States, I think. And it uses a 12 gene molecular score, four of which is the reference gene. However, I always like to mention that their better data comes from EP-CLIN score, which incorporates the tumor size and nodal status into, plus the S score, which is the EndoPredict genomic score. And you can see that the coefficient is 0.28 on the genomic data. So over 70% of the score from EpiClin comes from clinical data. So if I am paying a lot of money to do the genomic testing, I would like to get more information from the genomic testing. Nonetheless, they have good prognostic data published in clinical cancer research, and a lot of the doctors are using EndoPredict also in Korea and also in parts of United States and Europe also. So this is the history of multi-gene assays in the West. MemmaPrint was developed in 2002, Oncotype DX in 2004. Prosimna, which is based on the PAM50, was put out to the market in 2009 and EndoPredict in 2011. And it was followed by the TAILOR-X trial, MINDAC trial, and the Responder trial. As I mentioned earlier, we have different age distribution in Asia. And also, there are a lot of studies that shows contrasting pathology for Asian patients. So this is comparison between East Asia and United States. You can see there's a cross in the in the chart, the graph, at around 50, right? So for younger patients, there's a higher percentage of ER positive patients in Asia. And for TNBC, there's a higher percentage of younger patients in the United States. And also vice versa. And so high-grade patients and TNBC here. So we can see that there is some kind of difference, and these suggest racial differences in biology could be there. And also, they did an analysis for the patients in the TAILOR-X trial for Asian population. Although there was no difference in recurrence scores between the East Asian people and the West, Asian patients had better survival. I think this is a culture thing. Our patients listen to us better. They stick with the tamoxifen, right? So I think that's a big factor, but still, there's some kind of difference. And this study was conducted in Samsung Medical Center in Korea. They show that younger Asian patients have a higher proportion of luminal B in HER2 patients, and also more immune active microenvironment. And a recent paper from Yale shows that younger patients had higher rate of ESR1 copy number loss, and also lower mRNA expression of ESR1 and ER associated genes, and a higher expression of immune-related genes. And so there's some kind of difference for younger patients. And this was a nice summary done by Dr. Yap. We have a higher percentage of luminal B patients and a higher frequency of TP53 mutations and more active immune microenvironment. And because of this, and we knew that we could have different characteristics in the Asia. And so in 2005, CureBest 95 was developed in Japan, and it is being used in some parts of Japan, mostly in the Osaka area. GeneSwell-BCT is another test, RT-PCR-based test in Korea. Recurrent-Dex is a test that was developed in Taiwan, but it's only used for research purposes only. And today I will be talking about the OncoFree. So the motivation for development of OncoFree was two things. The previous tests were uses RT-PCR or microarray, but we are in an era of next generation sequencing, and most genomic tests are being used being done on the NGS platform. So we sought to develop it using this platform, and also we wanted to use our Korean breast cancer patient samples for the development and also validation. the advantage of using an NGS-based platform is that we can do it on site. We have to send Oncotype DX, MammaPrint, EndoPredict to a central lab in the United States, right? But if we use NGS, we can just provide the chemistry and also the algorithm, and you can just do it in the hospital itself, and that will save time and also expenses as well. So I'll make it brief. We had to compose it with a unique gene composition. We selected new genes. We started developing this back in 2014. So back then, targeted RNA sequencing using NGS was not so common. Nowadays, it's very, very common and generalized. We have to do the pipeline construction because we have to use the expression data from RNA sequencing and do the normalization. And then we had to do the algorithm development and then do a separate independent verification using independent samples. And when we developed the algorithm and did the verification, we saw this is our preliminary results. Classification according to Oncotype DX and OncoFree was correlated in 91%, and the Pearson correlation coefficient was 0.84. And we knew that our idea was to develop an algorithm that predicts the Oncotype DX recurrence score. That was the idea because we won't be able to conduct a prospective trial, get the tissues from the large-scale prospective trials, and and because most of the patients had received chemotherapy, we wouldn't be able to use our samples to develop it. So that was our idea. So we made this awesome, very good algorithm, but we weren't sure if it would be translated into predicting prognosis of actual clinical samples. So we did a separate validation using patients that had long-term follow-up data. Final median follow-up was 141 months, very long, right? We included patients that had not received chemotherapy for those that didn't develop distant metastasis, because if the patient didn't develop distant metastasis and received chemotherapy, we cannot be sure that the patient didn't develop distant metastasis because of chemotherapy, right? So, however, we included some patients who had developed distant metastasis, even though they had chemotherapy, to include a substantial portion of patients who were high risk. So this is the results. According to the score, which is called the decision index, that's the name of the score for OncoFree, and whether the patient had developed distant metastasis or not. The RSC curve, the AUC is 0.76. And the AUC for Oncotype DX reported back in 2008 was 0.69. I know that we can't do a direct comparison, but we knew that we were going in the right direction. Because we used different samples and different platform, different gene composition, we had to set a cutoff value for decision index according to using other statistical techniques, and which turned out to be 20. So for all 413 patients for validation, according to the DI of 20 or less, or over 20, which is high risk, and blue is low risk, the hazard ratio for high-risk patient is 5.86. 5-year, 10-year for low-risk patients is 97, 93%, high-risk 70. But according to age, for younger patients, the hazard ratio goes up to 7.2, while sustaining a hazard ratio of 4.2 for older patients as well. But remember, we included some patients that had received chemotherapy, right? So for our pure analysis, we did an analysis using patients that did not receive chemotherapy. That's 377 patients. And, oops, one of these slides is gone. But anyway, the hazard ratio was 8.7. And according to the decision index, we could estimate the 5-year, 10-year distant metastasis risk. And this data is incorporated into our report form. We give, according to the score, we give the estimated distant metastatic risk at 5 and 10 years. Again, for younger patients, hazard ratios goes up to 9.7, while sustained and this data for 97%, 94% for low risk scores, and 80%. Oops, I'm sorry, but the values are wrong. There's some mistake about the values, but the values for patients that did not receive chemotherapy is very, very similar to the 5-year, 9-year results of the Taylor-X trial. Okay, so we did this statistic analysis using the decision index, how they fare or influence the prognosis compared to other clinical values. We confirmed that it has the most influence compared to other clinical values. And this is, remember, for the development and verification cohort, there are 343 patients who has both the Oncotype DX score and the OncoFree decision index, right? So all these patients had the Oncotype DX, but according to clinical risks, about 50 to 60% of the patients are high risk, right? But they had done the Oncotype DX. According to Oncotype DX, recurrence score of 25, only about 10% was high risk. However, actually about 20% had received chemotherapy in the clinic. However, and according to the integrated recurrence score and clinical risk, however, because we had about 60% of our patients who were younger than 50, about 33% should have received chemotherapy. But according to the OncoFree test, the proportion of patients who were categorized as high risk was about 33%. It's not like matched one-on-one completely. However, the proportion of patients who should have been who are categorized into high risk is about the same. This was some data presented by our fellow this year using this 43 patients. Because there's the bias because all these patients were given chemotherapy according to the Oncotype DX, right? Yes, there were some patients who were high risk but did not receive chemotherapy. However, if we look at these patients, when we use OncoFree, we still can discriminate these patients. And also we can find one more patient that developed distant metastasis. And these numbers the hazard ratio is larger here because only 40 patients were categorized as high risk according to Oncotype DX. When we look at the patients who did not receive chemotherapy and look at the OncoFree results, most of these patients were low risk, right? If we can better give additional information to these patients who should have received chemotherapy according to OncoFree when we use compared to Oncotype DX. We do have some data for node positive patients in this cohort. There were 61 patients who were node positive. 45 of those were low risk, and all 45 patients, 32 patients, 40 patients did not receive chemotherapy, but all these patients who were categorized as low risk has no distant metastasis at 95 years of median follow-up. This is another retrospective analysis in Korea, 72 women in tertiary hospitals, premenopausal, node positive, but Oncotype DX recurrence score between 16 and 25. The 5-year distant metastasis-free survival is 95% without any chemotherapy. So we think a lot of the doctors think that the chemotherapy benefit from the responder trial is from ovarian function suppression effect from chemotherapy, right? So this was the background of this planned interstellar trial that's going to be opening up maybe in summer this year. The key eligibility criteria is hormone receptor HER2 negative breast cancer, premenopausal, 1 to 3 positive lymph nodes, and they will go under OncoFree. And if it's 20 and under, low risk, they will be receiving ovarian function suppression plus tamoxifen or AI. This is going to be a single arm trial because of the feasibility. We're going to enroll about 600 patients. And we compare this to this disease-free survival of the chemotherapy arm of the responder trial for premenopausal patients. Okay, which was 96.1%. There's also an upcoming trial called the NRG-BR009 planned in the United States. I think they call it the UPSET trial now. They will be enrolling nearly 4,000 patients. No negative, but intermediate recurrence score of between 16 and 25, and node positive for a recurrence score of 0 to 15, and node positive and 16 and 25. They're going to randomize patients into chemotherapy and no chemotherapy for premenopausal patients. I think they might be starting this maybe at the end of the year this year or maybe early next year. So I really think the paradigm shift has occurred for our hormone receptor positive, HER2 negative patients. As I mentioned earlier, I only did my fellowship back 9 years ago, which I think I realized that it's not so far away. Not that. So back then, we gave chemotherapy for most of our patients. So we used multi-gene assays to spare them of chemotherapy, right? That's when a lot of the patients were receiving chemotherapy. But now we know that most patients, majority of the patients would not benefit from chemotherapy. So we don't offer them chemotherapy anyways. But we use multi-gene assays now to avoid missing out on aggressive cancers that are hidden from the readings of pathologists. No offense to the pathologists, but it is very subjective sometimes, right? There's different grades, different Ki-67 values. For example, I'm sure Suzanne knows very well because she's been at ASAN, Samsung, and Seoul National University. Ki-67 score, the median value in Seoul National is 10%. In ASAN, it's like 20%. In Samsung, it's like between 15 and 25. It's very different. At another institution, it's 30%. So it's very, very different. So it's really difficult to generalize. But these multi-gene assays are those that can really make these markers very objective. But however, we need further trials warranted to answer these unanswered key questions. And we are doing our best to go through a series of validation tests. We're going through the FDA approval in Korea, comparison tests between Oncotype DX. Actually, we do have preliminary data of 413 patients in Seoul National University Hospital using samples that had gone under Oncotype DX. We actually have better correlation than the original development. It was 0.84, but our data is 0.86. We hopefully will be able to publish that within a few months. And we're going to do additional validation testing in using node-positive patients, interstellar trial, and also for the neoadjuvant chemotherapy benefit, using samples from the NEST trial that was conducted in Asa Medical Center. And we also have this late recurrence predictive factor data. As you know, for luminal type cancers, a lot of the recurrences occur after 5 years, right? So we have this data, excluding patients who had developed distant metastasis within 5 years, we can still discriminate patients for late recurrences at about hazard ratio of 5.14. Low risk patients have a 10-year survival of 97.5, and high risk patients 86.5. So we now know that extended endocrine therapy is beneficial in some according to some trials, but we have to remember that it has disease-free survival benefit, which includes contralateral, regional, distant, everything, right? And also other cancers as well. And we have to, yes, we can prevent new breast cancer in the contralateral breast. However, none of these trials showed any overall survival benefit. We do have some kind of predictive model called the CTS5 calculator. However, it was developed from a cohort of women with a mean age of 60. We do have data from Korea. When we looked at premenopausal patients, it's not predictive. So it shouldn't be used for premenopausal patients. So we developed this is like a preliminary name, but it's KCTS5. We named it. We're naming it we're in the process of naming a better. Anyway, we developed a model using machine learning, using about over 2,500 patients, premenopause patients, and we are using some of these, about 500 samples available of these 2,500 patients, to go through OncoFree, and trying to incorporate OncoFree tests added onto this machine learning algorithm to leverage predicting who would benefit from an extended endocrine therapy and who would not. Okay. And this is a long list of clinical trials that are already ongoing or planned. And I would like to highlight this validation OncoFree study we are planning in Singapore. Hopefully, we can have a lot of contributions from a lot of these hospitals in Singapore. So OncoFree, we do the RNA extraction, go through NGS, go through normalization pipeline algorithm, and we put out a score. And I told you about the advantages of NGS-based testing and a test developed using Asian samples. This is the report form. We present the decision index, category, and the risk of distant metastasis at 5 and 10 years. And according to risk, if it's low risk, we recommend endocrine therapy only. If it's high risk, we recommend chemotherapy also. And this is a little comparison between the other tests, OncoFree and Oncotype DX MemberPrint. And the biggest differences is the sequencing technology. The older ones use PCR or microarray, but we use NGS. And the price, we're about half price. So we're trying to offer more to our patients, more opportunities to go through these tests. So this is the current status in Korea. We have orders from 70 tertiary hospitals. And by the end of 2022, we had about 2,600 tests used in these hospitals, all the major hospitals in Korea. The orders are going up. This year, we already have about, I think about 600, I think something like that. And this is the data presented by Dr. Jongwon Lee at GBCC. He showed us the data for Oncotype DX and MemberPrint. We don't think that we overtook MemberPrint. I think our role is more so to expand the total tests being tested in Korea, to give the patients more opportunities to get additional information so that the clinicians can use more information to decide on the adjuvant treatment. So we have started testing in Thailand, and we are having talks with other sites in Southeast Asia, Taiwan, and also in the Middle East. These are some of the statistics. About 35%, 36% are high risk according to the decision index of 20. However, in actual practice, Professor Wanshik Khan and myself, we use different cutoffs for postmenopausal patients, and we look at the other clinical values. So when I usually use, should be 22. I usually use about 23 to 24, and they about 23 to 27% of our patients receive chemotherapy. Professor Han uses a cutoff of 25, so about 20% of his patients receive chemotherapy. This is just a case. This participant patient had a DI of 31.8. She refused chemotherapy, but after about a year and a half, she developed liver metastasis. So I don't know. We can't be sure if she would have not developed liver metastasis with chemotherapy. However, anyways, and we have one case with low risk OncoFree that developed liver metastasis at another institution. Actually, we did a biopsy on that liver tumor, and it was triple negative breast cancer. So this is that we missed because of the heterogeneity of the cancer itself. So this decision was founded in 2017. Dr. Youngjun Che here is the Chief Strategic Officer. I'm serving as the Chief Medical Officer. That's why he's here, kind of, you know. So our goal is to meet to address the clinical unmet needs, and develop tests that going to be actually used in the clinic. And to be used in the clinic, it has to have clinical utility, which means that it translates into clinical decision making, and it comes from the clinical experience. That's why we are the founders are mostly clinicians actually seeing patients, and all these products are being developed according to this very core value. And using this NGS experience, algorithm modeling, and clinical validation, I would like to introduce, because it's a general surgery meeting, I would like to briefly introduce surgery-free. OncoFree is to free patients of chemotherapy, right? And cancer. Surgery-free is to free patients of surgery. Yes, we are surgeons, but we're trying not to do surgery. For thyroid cancer, if we do an FNA or corneal biopsy, 5% is malignant, 70% benign, but 25% are indeterminate. But for these patients, we have to perform surgery or lobectomy in order to discriminate, to diagnose if it's malignant or benign, 70% of which end up being benign. So, which means that it could be, so the 70% of the patient, these indeterminate patients receive unnecessary surgery, right? So we are in the final stage of developing this genomic multigene test to go through the algorithm and discriminate these patients into benign and malignant. If it is benign, we will offer observation for the patients and spare them of surgery. And he's the key developer here. So these are my final slides. We had a fun time last month. We meet each other within a month period, right? So we had some good Korean dinner. This was at the beginning of the dinner, and this was at the end of the dinner. You can see the difference, right? From all the alcohol, right? And this was final after the dinner for the short visiting program for young doctors from all of Asia. We had several participants from Singapore, and I had the honor of having a lot of observers for my robotic case. It was fun to have them here. And the GBCC, this was from the Junior Doctors Debate. We have a lot of active participants. And the first ever non-Korean leader in Suzanne Lim over there. And also the short visiting program. We had a lot of fun. And even some Suzanne here and Wei Wen. Wei Wen from Tantok-seng. He's doing a one-year fellowship at our institution. We also went to the Norebang, which is the karaoke, Korean karaoke. So I would like to briefly notice the GBCC next year. It's just going to be from April 25th to 27th. Yes, I am the Deputy Secretary General at GBCC. And I would like to thank my our team at SNUH, Professor No, Professor Han, Professor Moon, and all our fellows, graduate students, and researchers, and also our members at our company. We have 38 employees now, and all this beautiful work was done with the help of all these awesome people. And thank you very much for your attention. And I would be happy to receive any questions and discuss. Oh, Wei Wen. He's actually in Korea. This is my professor in English. Such a cute wordplay. Okay. Oh, Dr. Yap. Great talk. Okay. Any questions? Yes. Right. Mhm. Mhm. Yeah, so the Taylor X trial was feasible because it was conducted in the United States, where there's so many patients, right? Um, we did some sample calculations, and we need several thousand patients for that. And by the time the results come out, there might be other tests or um, I don't know. So it's not going to be feasible. However, we are going in the process of doing a trial looking at chemotherapy benefit. So we do have 430, about 400 patients who did not receive chemotherapy, right? We have a distribution of OncoFree decision index. Um, and according to the distribution and the distant metastatic risk, we're going to enroll patients who had received chemotherapy, about 1,200 or 1,300 patients from multiple sites in Korea, to go through OncoFree testing, and that will put out a distribution of distant metastatic risk, right? So it's going to be a similar, we're going to have two graphs for patients who did receive chemotherapy and who did not receive chemotherapy. So the hypothesis is that for lower decision index scores, there's going to be a small or no difference in the risk of distant metastasis. For higher risk scores, there is going to be a difference for distant metastasis for patients who had received chemotherapy and not, right? So we won't be able to conduct this study that could put out data for chemotherapy benefit, but we will go through a large scale retrospective study that can hopefully show the difference between low risk decision index scores and high risk decision index scores for distant metastatic risk. Hopefully next year, maybe end of next year. Yes. Mm-hmm. 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 Right, right, right. So I actually don't think that there's going to be a significant difference between ethnicities because it's an analysis of the tumor itself, right? Although I showed you some data that are differences between younger and older patients and Asian Western patients. However, I believe that those kind of differences are compensated in the OncoFree because it was developed using Asian patients, and the cohort for the development phase, about 62%, 63% are younger patients. So I think OncoFree, we will have to do more studies and show more validation data, but I do believe that it will be more reflecting our Asian population better than some of the tests developed in the United States or Europe. So for Oncotype DX, for their development phase, where they use the NSABP 14 and 20 tissue, their their proportion of younger patients is about 30% still. So, and the phrasing that Dr. Uh, uh, Fatima Cardoso used in a talk in San Antonio was that these Oncotype DX and MammaPrint is constantly underrepresenting younger patients. So they should be cautious. And some of the guidelines in Europe are saying that they should not use MammaPrint for younger patients as well. So Although they're planning these node-positive trials using Oncotype DX and MammaPrint also in Europe. I forgot, I didn't mention it here, but we'll have to see whether the test results and using only rare function suppression could be predicted using those tests as well. Hopefully, it can be validated for all tests. That's truly my wish, because we are trying to do this to offer our patients the more opportunities to go through these tests, to give our physicians more information to make decisions with their patients. So I truly think that all these tests should contribute in trying to validate the benefit from chemotherapy or rare function suppression, and we don't know this for sure, right? So we have to work together to really address this topic. Yes. Right. Yes, we mainly do it on probably 99% we do it on surgical samples, but doing the test on corneal biopsy samples is possible. We do have data that it correlates very well. So we have this trial called the Plateau trial. It finished enrollment last year. The PI is Dr. Wanshik Khan. It uses MammaPrint to decide whether to give the patient chemotherapy or neoadjuvant chemotherapy and neoadjuvant endocrine therapy in an effort to bring the BCS conversion rate for patients who would not be able to do a BCS before neoadjuvant treatment to BCS after. So for tailored treatment in terms of surgery, that's going to come more and more. We do have a lot of studies going on. So I'm sure we can use these genomic assays for corneal biopsy to get the information for tailored neoadjuvant treatment as well. And the technology, RT-PCR, NGS, is very, very possible. It's very, very feasible using corneal biopsy as well. We're using FNA samples for thyroid cancer. So, yeah, we're doing the cytology here. Mm-hmm. Yeah. Mm-hmm. Mm-hmm. Yes, yes, of course. But yes, very, very good point. However, I'm sure you all have experienced that it's a pretty advanced luminal type cancer, a lot of nodes, but we offer them years of chemotherapy, but there's no difference, right? No response. And we have to do total mastectomy anyways, right? So I kind of tend to go do upfront surgery for luminal type cancers anyways. And offering the patients for genomic testing for these patients beforehand might be too much, maybe. If the patient had received surgery for pathologic staging, she might not have needed the genomic test. So if the test is maybe $100 or maybe $1,000, okay, so I think that'll be okay. But if it's like $2,000, $3,000, $4,000, I think it should be spared for patients who would really actually need it after proper pathologic staging. So that's another issue. Yeah. 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 Right. Mhm. Yeah, I know. It's supposed to be a secret, but everybody knows about it. Yeah, I know, but that's because Oncotype DX, they have a smaller portion of high risk patients, right? So I think that maybe I'm sure they did the math, but anyway, yeah, yes, Rina. Yes. Oh, okay. So in Korea, we have to go through Korean FDA approval. We are in the process of that. We're expecting the approval early next year. Um, Once we get that, we can do the test in Korea. We expected the turnaround time to be within 1 week, but now we have to do the NGS testing outside of Korea because of regulations. So we send our samples to our collaborator in Hungary. It's a spin-off company from a national-run biomedical institute. They do very well with the testing. We send our samples to Hungary and come back. The turnaround time is about 2 weeks, 2.5 weeks. And that's about the same as the Oncotype DX in Korea. Mhm. No, it will be shorter because we will be able to send the samples to Korea to our lab. We have much more flights. We have like 6 flights between Korea and Singapore, right? SQ and Korean Air, right? So it's gonna be much faster. And the processing, we can do more, uh, have more our researchers on that program. So for our orders from Thailand, it took about 10 days to report. So. Mm-hmm, mm-hmm. Yeah, right, right. Yes, it's all about regulations. Is we have been looking into this for several years. It's all about the regulations. Would they allow this testing in a accredited lab only, or will we have to go through FDA approval in Singapore? Would the other data that we do go through in Korea would be enough, or do we need some kind of data from Singapore? Those things we don't know. We have to actually go through it to get the answer. That's why we think it's a good start to that would be to collect retrospective data using Singapore in cancer patient samples to get the basic data, and then potentially go through some other additional tests to yeah. So ideally, it would be best to have the core lab here in Singapore and get all these samples from other parts of Southeast Asia come in. And so, are you interested in? No, I just. Yeah. Yeah. That's one of our very important things that um, our core members are working at right now. So hopefully soon. No, Singapore dollars. Singapore dollars. So Korean won, it's about 200, no, wait, 200만 원 뭐지? 2 million Korean won. 2 million Korean won. So yeah, 2,000 Sing dollars. Yes. In Korea? No, not yet. Yeah. So we have a very complicated system in Korea. We have to get approval from the FDA, and then it takes about 3 to 4 years for it to get covered by insurance. So hopefully we can get that done. No. So Oncotype DX has no approval from anywhere in the world. You know that, right? So the only test that has FDA approval is MammaPrint. In the United States, it's MammaPrint, and EndoPredict. I'm not sure, but that's the only test that has the FDA approval. So Oncotype DX has the lab approval, the CLIA lab, and that's how they do the testing, and that's why we have to send the samples to that lab. So I had the chance to visit that lab. Yes, I noticed them that I'm the founder of Decision, and it's no problem to come. And I had a chance to visit their lab in Redwood, near San Francisco in the United States, and it's a very big facility. They have like thousands of orders every week, right? So, but the problem is, they don't show the actual lab that does the testing. That's their core, and that's the problem with RT-PCR. The quality control is very, very difficult, and if it changes labs, you have to go through everything. So that's why they can't set up a lab outside of that facility. For NGS, it can be done anywhere. That's why MammaPrint developed an NGS version using the 70 genes, and for this purpose, to localize the testing. They're not using it commercially yet, but they have a couple papers on it, and they're trying to do that. But because it was developed using microarray, they have some difficulties translating into NGS. For us, Oncotype DX, a reference gene in Oncotype DX is one of our most important genes for our algorithm. That comes from the different platforms. So that's kind of the scientific part of that.
Okay, so I bet you also
Yeah. You can contact me anytime.
very much for essays and sharing with us about the OncoFree. I'm sure it's going to be a very promising thing for patients for it's easier to access and the price as well. So, and thank you everyone for coming here to KK and for those who have joined us in the Zoom meeting. Professor Lim Gyok-kun, our head of department, has something prepared for you. It's the appreciation of a token of appreciation. Yeah.